Welcome, Professor Hesse. We are pleased that you are available for an interview with us today. I would like to start off by asking you to introduce yourself. Yes, thank you. I am a medical specialist for neurology, physical medicine and rehabilitation. In conjunction with my work group, I have been involved in the rehabilitation of stroke patients for 20 years. I currently hold the position of head physician at the Medical Park Clinic Bad Rodach. In the future, I will be working at the clinic in Berlin and be involved in scientific cooperation with the Charité. Thank you for that introduction, Professor Hesse. Now we would also like to know what your laboratory focuses on. Our scientific work focuses on restoring motor functions after a stroke, especially restoring the ability to walk and, in recent years, the problems associated with severely affected arm following a stroke. Thank you, Professor Hesse. That takes us straight to our main topic, the severely affected arm, along with the shoulder-hand syndrome. Now to the first question, how is the shoulder-hand syndrome identified and how often does it occur? The shoulder-hand syndrome is a very frequent problem in the rehabilitation of severely affected arm. Rates of incidence specified in the applicable literature fluctuate between 20 and 60%. The patient complains of shoulder pain and is afraid to make arm movements of any kind. Shoulder pain is frequently accompanied by swelling of the hand. I can imagine that this is very difficult for the patient. What is the impact of the shoulder-hand syndrome on patient rehabilitation? It is very unfavorable. The patient is almost exclusively preoccupied with shoulder pain and the related therapy, which means he is unable to focus on actual rehabilitation itself. Accordingly, the applicable literature confirms that the occurrence of shoulder-hand syndrome has a negative impact on rehabilitation. Could you please explain the causes of shoulder-hand syndrome in detail? There are several causes. For proper understanding, I think it is very important to know that the shoulder joint is a joint stabilized by muscles. As a result of paresis, following a stroke, the pectoral girdle is weak, so that the humerus head slides out of its socket, resulting in subluxation. Could you also please explain the exact causes of shoulder-hand syndrome? There is no single cause of shoulder-hand syndrome. We believe a number of factors are at work. First of all, there is the paresis of the pectoral girdle, causing subluxation of the humerus head. Then there is the disturbance of shoulder kinematics, so that when the arm is raised, the shoulder blade fails to follow but remains stationary. As a result, the humerus head impacts the acromion as the arm is raised. This leads to inflammation, which in turn causes shoulder pain. In summary, there is the paresis of the pectoral girdle, subluxation and inflammation caused by the disturbance of shoulder kinematics. Based on your experience, what are the essential measures to prevent shoulder-hand syndrome? Based on the described pathophysiology, it is crucial for us to try, and this refers to everyone involved in rehabilitation, to prevent inflammation of the shoulder joint. Adequate shoulder handling is essential in this regard. This means the arm must never be raised unprotected and without involving the shoulder, but always in conjunction with scapular mobilization. Good. Thank you, Professor Hesse, for the explanation of shoulder pain following a stroke. We know that you, in cooperation with Otto Bock and your work group, have made a significant contribution to the development of a new shoulder orthosis, the Omo Neurexa. What exactly are the objectives behind the Omo Neurexa? The Omo Neurexa is suitable for the prevention and therapy of shoulder pain following a stroke. Based on the pathophysiology, the purpose of the Omo Neurexa is to stabilize the shoulder joint and, in case of subluxation, to recenter the humerus head. A third key characteristic of the orthosis is to prevent the dreaded flexion spasticity of the arm as long as the orthosis is worn. This is achieved by two components, intelligently linked by a harness, so that the forearm is not flexed but kept extended in the supination position. As we know, there are already numerous orthoses and treatments for shoulder pain. What exactly is different about the Omo Neurexa? According to our current state of knowledge, the Omo Neurexa is extremely well suited for recentering the humerus head. This is achieved by an outstanding fit and material characteristics, so that the orthosis adapts to the arthropic shoulder. In addition, for example, compared to a triangular bandage, it helps to keep the arm extended in the supination position and thereby prevents the development of flexion spasticity. In order to be effective, an orthosis has to be worn all day. How is the level of wearer comfort? In order to assure the highest level of wearer comfort, Otto Bock selected an extremely skin-friendly material which not only adapts optimally to the paretic shoulder but also absorbs perspiration and regulates temperature. Our patients agree that the level of wearer comfort is very high. Another question, who puts on the Omo Neurexa in the morning? We originally hoped the patient would be able to do so, but this did not prove to be practical. This means that during the early stages of rehabilitation, this is mainly the responsibility of nursing staff. It is extremely important for nursing staff to be properly trained with corresponding instructions and orientation. What happens once the patient goes home? Can a family member take over this responsibility? As their functional status improved, we have known patients who were able to put the Omo Neurexa on independently. Otherwise, family members can definitely do so. Are there any study results for the Omo Neurexa in addition to clinical experience? Yes, there are. In conjunction with an Italian clinic, we have studied several patients with the Omo Neurexa who wore the orthosis for a period of 4 weeks. X-rays showed that recentering of the shoulder was very good and that the joint gap narrowed significantly after 4 weeks. So what did the patients have to say about wearing the Omo Neurexa? That is another important point. The level of wearer comfort was assessed as very high, and the patients were very satisfied. This was also documented by the fact that none of the patients stopped using the orthosis early and that it was worn all day. What about the development of pain when wearing the Omo Neurexa? For one thing, we can say that there are definitely patients who are at risk for the development of shoulder pain and that wearing the orthosis was able to prevent that. Then there are patients who already complained about shoulder pain at the beginning of the study. Here the results are not uniform. On the one hand, there are patients with desirable results who say, yes, wearing the orthosis helps me and I'm experiencing less pain. On the other hand, there are also patients who say there was no effect on pain. What we learned in the study, although this is by no means new, is that pain is experienced very subjectively and is affected by many external factors, such as depression, or a patient's realization that he may be permanently disabled. These factors affect the assessment of questions related to pain. What did the therapists have to say about the Omo Neurexa? The therapists were surveyed with the help of a questionnaire. In summary, I can say that the therapists were also very much convinced by the Omo Neurexa. Of course, they initially feared that wearing the orthosis would promote the development of flexion spasticity. This did not occur. They were also concerned that wearing an orthosis would reduce the mobility of the shoulder joint. However, the extent of passive shoulder joint motion remained unchanged. A third point, very much appreciated by the therapists, was that the shoulder can be therapeutically mobilized without removing the entire orthosis. This is because the two components, the forearm cuff and the shoulder section, can be separated easily in a few simple steps. Professor Hesse, what influence did the Omo Neurexa have in regard to therapy? From our point of view, this was the most favorable result. Patients and therapists agreed that gait rehabilitation in particular was facilitated by wearing the Omo Neurexa. We see this as follows. Without the orthosis, the patient has to focus on securing the paretic arm. When wearing the orthosis, this need is eliminated, so that gait rehabilitation was more effective. Did anyone investigate this outcome, that is to say, are there any gait analysis results? Yes, we carried out a gait analysis which showed that the patients were able to take longer steps and, based on the derived muscle activity, were also able to put more weight on their paretic leg. This in turn resulted in more defined activity of the thigh extensors when wearing the Omo Neurexa, compared to when patients walked without the orthosis. Was this positive result only apparent in gait rehabilitation or also during other activities? Yes, the patients learned to value this supporting effect quite highly and did not want to go without it during activities related to their morning routine, such as washing, having breakfast, the transfer, etc. Some patients even said that the first thing they do in the morning is put on their Omo Neurexa, and the last thing they do at night before going to bed is to take it off. These results certainly sound very promising, but can we actually say that this represents a secure level of evidence? No, we cannot. This is an initial open study which encourages us to conduct a controlled study as the next step. We are currently putting together such a study in conjunction with Otto Bock. At this point, we have not decided whether the orthosis will be compared to another orthosis or a different therapeutic approach to the treatment of shoulder pain. I would just like to quickly review cooperation between your work group and Otto Bock. What are the objectives of this partnership? As you know, Otto Bock has been mainly engaged in prosthetics and fittings for orthotics patients, very successfully. As a representative of neurological rehabilitation, I am all the more pleased that one of the largest medical technology companies is now also dedicating itself to the needs of stroke patients. For a company like Otto Bock, it is understood that this will not be limited to a single product, but that an overall orthotic fitting strategy for stroke patients will be developed. We hope to support Otto Bock in this endeavor. Otto Bock has also been very successful in the field of functional electrostimulation with innovative implantation technology.